Welcome to Conference Highlights, recorded in front of a live audience at an evidence-based perioperative medicine, that's EBPOM conference. EBPOM are world leaders in perioperative education, so why not join us at our next meeting with a special discount for Top Med Talk subscribers. Look us up on www.ebpom, that's ebpom.com. Top Med Talk.
I'm first going to introduce Chloe Grimmett, who is a behavioural scientist from Southampton, and she's been working very closely with the Fit for Surgery team in Southampton with a behavioural intervention, which is part of our randomised WestFit prehabilitation trial. So, with no further ado, Chloe.
Okay, good morning. Firstly, thank you for inviting me to talk to you today. As Denny said, I'm a behavioural scientist. I'm based at Southampton. And I've got a split role at the moment, so I'm a senior research fellow in the Macmillan Survivorship Research Group at Southampton Uni, and I also work on a NIHR postdoc fellowship, and in between all that I support Sandy Jack and the team at Southampton in the Fit for Surgery study. So I'm going to talk to you a bit about how we've gone about introducing behavioural science into the perioperative world. I'm sure most of you are aware, as we've already heard, that in the last few years there's been emerging evidence for the role of exercise prehabilitation, and I'm talking today particularly about cancer. That's the area within which I've worked since my PhD. So there was a systematic review recently, just published this year, which suggested there's now convincing evidence that prehabilitation exercise prior to cancer surgery can reduce hospital length of stay, post-surgical complications, and improve or maintain functional capacity. And there's also some emerging evidence about the potential for this to impact on tumour regression. So this is all very exciting, and over the last few years there's been a lot of evidence emerging in this area, but almost exclusively the focus has been on mechanisms of action and the physiological outcomes associated with prehab exercise. As a behavioural scientist, I'm interested in the potential for impact on psychological outcomes and also around patient behaviour. So as Denny suggested, might these preoperative exercise interventions not only initiate exercise during that particular period of time while they're doing the preoperative exercise, but could this lead to longer-term behaviour change? And we know that patients who are waiting for cancer surgery, it's an incredibly stressful time for them. They often feel they don't have much control over the situation at that time. There's a lot of fear and anxiety and psychological stress. I'm sure I don't need to tell any of you guys about it. You work with these patients all the time. I should also say I'm not a clinician, so don't ask me any tricky clinical questions. So my exercise, my involvement in these prehab exercise settings, might this have some sort of impact on those psychological outcomes? And might it also motivate people to exercise beyond their cancer surgery? Most of the evidence has been almost exclusively, really, in the physiological outcomes. There's been a couple of studies now that have looked at some qualitative data in this area. The Fit for Surgery team at Southampton, who I'm sure many of you are aware of, they did some qualitative work with some of the patients who'd been involved in one of their exercise prehab trials. And they wanted to talk to the patients about their experience of being involved in this study and what impact it might have on their quality of life. So it wasn't the primary outcome, but it was something they looked at later on. And some of the really commonly emerging things that came out from that was that patients talked about having an increased sense of vitality. They had a much more positive attitude to what was going on, and they had a strong sense of purpose. And this feeling of having an increased sense of control was really important. So this quote here on the right talks about this patient who says, "It helps me feel like I'm taking control and doing something for myself." So at a time when they're being done onto very much, this gives them an opportunity to take a bit of control themselves. So in another qualitative paper, the Fit for Surgery team wanted to talk to people about their experience of actually doing the exercise and being involved in it. I'm sure many of you know that the Fit for Surgery school have got some absolutely fantastic adherence rates to their prehab exercise trials. They average, I think, Sandy, around 96%. So the patients that sign up for these things are hugely motivated and engaged and stay the course for what can be quite long prehab exercise trials. So why are they doing that? Why are they so motivated to be engaged? And again, this sense of control came up again. And they also talked about being motivated to exercise in the future, which is very encouraging. And they talked about camaraderie and peer support. So in this trial, I think I'm right in saying they exercised in pairs. And the patients really felt a benefit from that, feeling like they had peer support with someone else going through the same thing at the same time. And they were hugely complimentary of the team delivering the prehab exercise and the camaraderie and the support they felt from that. So this person says, I'm determined more so than ever to keep this up. I'll do longer walks to keep up my fitness and maybe even get on my bike. So people were talking about having received this benefit from exercise and wanting to do some more in the future. Now, going off on a bit of a slant, but bear with me because this is relevant. My work at the Macmillan Survivorship Research Group, the team there have got a really big programme of work funded by Macmillan, which is designed to increase our understanding of the trajectory of recovery of patients who have been diagnosed and treated for cancer. So we all know there's a really ballooning population of cancer survivors as treatments improve, but we still know surprisingly little about how well people recover in terms of their health and well-being and why some people might do better than others. So the programme of work at the MSRG is designed to understand more about that. The first signature project from the MSRG was the CRUISE study. Now this was a large prospective cohort study. It includes around 1,000 colorectal cancer patients who were diagnosed with non-metastatic disease, so disease to be treated with curative intent. And it's a representative sample, so 96% of eligible patients were approached. There was a really high response rate, so the first questionnaire, I think, was completed by about 78%. And really importantly, that first questionnaire was completed at the point of diagnosis and before any treatment had started. So we've collected data periodically for 5 years, and we're just starting to publish the 2-year data now. In this paper, we were really interested in looking at the trajectories of recovery. So as I said, looking at patients' recovery of health and well-being over those first 2 years from the point that they were diagnosed. So the trajectory showed that patients fell into one of 4 of these trajectories. And this is data from the QLACS, which is a cancer-specific quality of life measure. And lower scores indicate better quality of life. So the patients tracking on the blue line are doing the best, and so on up to the yellow line, and those people are doing quite poorly. So you can see that around 70% of people are in that blue and red line. So at the point they're diagnosed, their quality of life is quite good, and there's not a huge amount of deviation over those 2 years, so it stays relatively constant. That's true for the other 2 lines as well, and those are the people that aren't faring so well. Those people in the top band are really, really struggling. And we can see that they're struggling at the point they're diagnosed. That's before they've received any treatment at all. So we see these trajectories, and then what we were interested in, well, what factors predict which trajectory a patient falls into? So essentially, what things makes it more likely that someone's going to be in those top 2 tiers, the ones who are doing poorly? And we looked at psychosocial factors, personal characteristics, and clinical stuff. And we found that the 2 most significant predictors of group allocation was self-efficacy, so that's a person's confidence to manage their disease and their illness, and depression. And that stands true even after controlling for personal characteristics like age and gender, but also their disease and treatment characteristics. So it doesn't matter what stage of disease they were, it doesn't matter if they ended up with a stoma, it doesn't matter if they got chemo-rad, or just surgery. Confidence and depression were some of the key predictors of how well people did over the time course. And importantly, we know that self-efficacy is something that we can change. So people who are struggling, we can potentially help them to improve. So that really sings to this prehab exercise notion. So if we can support patients right at the point of diagnosis, which is where the pre-operative exercise stuff comes in, then maybe we can also support their health and well-being afterwards. Okay, so what about behaviour change? So I'm a behavioural scientist. This is the stuff that I'm particularly interested in. We know that while these prehab exercise trials that have been conducted so far, they've been almost exclusively in hospital-based settings. So it's highly supervised in a hospital over a given period of time. And we know that despite the fact that there's really encouraging evidence there, we know that that's not sustainable in the NHS. We need some kind of alternative method for delivering these interventions, be it in the community or as a home-based trial. Now, acknowledging that, the Fit for Surgery team came up with this trial where they looked to start patients with a prehab exercise program in hospital and then transitioning them into a home-based setting. So they start off in hospital and then they're given a program to do when they're back at home. Now, the adherence rates for that went from 96% when they were in hospital and supervised to 8% when they went home, which was obviously a bit disappointing for the team, I'm sure. And also it's a case of, well, we know the patients are motivated. They're doing it in hospital. We've seen the qualitative evidence that they really feel the benefit of what's going on. So why the drop-off? So while the team at Southampton were scratching their heads about this, Sandy, Jack and I had a chance meeting at the hospital at Southampton where we were both presenting our work, and we started to talk a bit about how we might include behavioural science into some of the future studies. So, as I said, my background has been in developing interventions for cancer survivors. So I've been, up until now, very much involved in patients after they finish their treatment. And there's been a lot of research in this area over the last 10 years. So we have some pretty solid evidence now that we can develop interventions in all sorts of settings which are effective in changing patient behaviour to increase their exercise once their treatments have completed. So we've got evidence for home-based settings, web-based interventions, individual or peer support. They can all work. And there's been some fairly recent systematic reviews that have showed some pretty decent effect sizes in affecting short and medium-term physical activity behaviour. And importantly, the interventions that had some kind of theoretical underpinning, so that were informed by behavioural science, seem to do best. I essentially started talking to Sandy about how we can move some of the learning in this area into the preoperative setting. And what we saw in that trial where the patients were trying to go from this supervised exercise setting to the home-based setting, they left with a spring in their step. They left wanting to exercise at home. So they had the intention to do that. But it didn't happen. They didn't manage to do the exercise independently. And we've all been there. We've all seen in our own lives this intention to behaviour gap. So we intend to do something, we're really motivated, we know it's a good idea, but something gets in the way and the behaviour doesn't happen. And this is where the behavioural science can come in to try and understand that gap and bridge that gap. So I think it must have been early 2016, the team at Southampton, led by Sandy Jack, secured a £1.6 million NHS England service transformation bid. And this gave them the opportunity to develop a four-armed RCT to embed within a service transformation. If you want a lot more detail about that, I'm sure Sandy and the team will be happy to talk to you about it later. I'm just going to give you a brief overview. So there's four arms to the trial. There's the control group, or the standard care. Group 2, they receive exercise alone, but this is in a community setting, so this is in local community gyms. Group 3 receive psychological support, and that comes from Wessex Cancer Trust wellbeing centres. And then Group 4 receive both exercise and psychological support. And my job was to find a behavioural intervention that we could embed within the exercise elements of that trial to try and support patients to maintain the exercise when they're in this community setting, and also to hopefully give them the impetus to exercise after the trial has finished, in as much as the supervised exercise element has finished. So it needed something that was pragmatic. We needed something that didn't involve a huge amount of training for the people delivering it, and we needed something that wasn't overly burdensome on the patients. Now, I don't know how many of you have come across the Making Every Contact Count initiative. Has anyone heard of that? Yeah, quite a few of you. So this was the brainchild, if you like, of Public Health England, NHS England and Health Education England, and it was their effort really to try and address this public health crisis we have of people having poor lifestyle habits. They developed, or an intervention was developed to support health professionals across the board, anyone who's interacting with patients or clients, to try and use those encounters as effectively as possible to try and promote behaviour change. Now, the crux of that intervention is something called healthy conversation skills. And that was developed by someone called Professor Wendy Lawrence, who also happens to be at Southampton in the MRC unit. And they developed this intervention that draws on behavioural science. So it draws on motivational interviewing, which some of you might have heard of. But most of all, it draws on Bandura's social cognitive theory, which is essentially this notion of self-efficacy. That's the real core component of it. So if you can increase people's confidence and give them a real sense of autonomy over what they're doing, then you might have a better chance of them doing it. And this is really shifting the balance from being given an exercise program and told what to do, how to do it, and when to do it, to asking the patients what they want to do and how they want to do it, and to make sure they think about any barriers that might come up. So it's really about fostering this sense of empowerment and doing that through problem solving, self-directed, graded goals and action planning, which in plain English basically means the person becomes a facilitator, talks to the patients about what they want to do, what are their goals. So it might be that someone just wants to get fit enough to get back to playing with their grandchildren or getting back to cycling, whatever it is that they want to be doing. That's their ultimate motivator. It has to be relevant to them in their day-to-day life. And they have to think about how they're going to go about doing that and think about what they're going to do if things get in the way. So the person delivering this training, is asking a lot of questions and doing a lot of listening and doing very little directing. So it's all about encouraging the patients to find their own way. So the training itself is delivered in 2 half days, spread over a couple of weeks usually in a group setting. And these are the 4 key components of the training. So as I said, it's about asking open discovery questions, the how and what. So what do you want to do? How are you going to do it? What are you going to do when this happens? How are you going to deal with that? Doing a lot of listening, more than talking, and the people delivering the intervention are encouraged to reflect on the practices. So think about how it went, think about how the conversation evolved, how might they improve things moving forward. And it's really about supporting this goal setting. I'm sure you've all heard about SMART goals. It's about them being realistic, achievable, so that patients can start making small improvements and working towards these bigger goals. So in the context of Westfit, this has meant that the personal trainers who are delivering the exercise trial in the community setting are being trained in healthy conversations. So while they're having these one-to-one sessions, and there might be 2 patients exercising at a time, while they're doing that supervised element, they're trying to encourage patients to think about these things, think about how they're going to exercise on their own, think about what they're going to do after surgery and how they're going to achieve it. They might do some signposting as well to things that are available in the community, and they'll make sure that whatever the patient is planning on doing, it's safe and sensible as well within the context of what's going on. So in terms of the outcomes for the Westfit trial, just to give you a sense of those, so the primary outcome is hospital length of stay. Now, that wouldn't be the chosen outcome were it Sandy's choice, but this is a service transformation fund, ultimately, and the bottom line for commissioners is hospital length of stay, so that's the primary outcome. And there's a number of secondary outcomes as well. So one of the ones I'm particularly interested in is physical activity, so we're giving people actigraphs to wear to measure their physical activity in the months after the trial. And also patient activation measures. Some of you might have come across the PAM, the patient activation measure, which is just another way of looking at this confidence to self-manage as time goes on. Okay, and then just one more thing. In the way that the Westfit trial was developed, while we were trying to iron out what the intervention was going to look like, myself and some colleagues ran some focus groups with some patients who'd already been involved in some of the trials at Southampton. And we asked them about their experience and asked for their advice on how we might change how things have been delivered in the past to make them even better, essentially. One of the really key thing, and in fact I think everybody that we spoke to talked about this, was having support after surgery. So a lot of them got frustrated in that they really felt their fitness improve, they really appreciated the benefits it gave them in terms of their recovery after the operation, but they didn't know what to do afterwards. They didn't know what was safe, they didn't know how to manage the fact that they'd had major surgery, what they can do, how they can avoid hernias. And so they really didn't know how to get back to exercising, even though a number of them wanted to. So one of the things we've included in WestFit is to make sure that all the patients have the opportunity to speak to their trainer around about week 12 or when they're medically fit to talk about any concerns they've had, what the plans are, and give them some confidence really that what they're doing is safe. They also wanted some nutritional assessment as part of the programme, so that's been included, and they talked about that benefit of exercising in pairs, so where possible we're going to do that. And at the end of the trial, well, actually after 30 patients in, we're going to start a process evaluation where we're going to talk to patients who've been involved and see how it's going, and talk to the staff delivering the programme, and then we're going to do a process evaluation at the end. And that will give us a real sense of, A, whether it's implementable from a service point of view, and B, about the experience of the patients as well. Okay, that's it from me. Thank you very much.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.